Hello friends, my name is Dr. Saf and today I am going to take the class on obstructive lung diseases, and this is the part 1 in which I will be speaking on COPD, pathophysiology and various definitions and how to assess the severity of the COPD, what is the definition of acute exacerbation of COPD, how do we manage, what are the management purse, all those things we are going to discuss in this video. And in the next part of the series on obstructive lung diseases, we will learn about the ventilatory management. And in the next series, that will be the last and third part of obstructive lung diseases, we will discuss about asthma. So at the outset, I would like to say that the COPD rank fifth in the burden of disease, and it ranks third in terms of mortality worldwide in 2020. ICU admission is required in more than 25% of patients with COPD at some time during their course of the disease. So let's start with the case presentation. A 65-year-old male patient, diabetic, hypertensive, and chronic smoker presented to emergency department with the chief complaints of difficulty in breathing, worsening cough with purulent expectoration for last 2 days, and drowsiness for last 8 hours. Patient had history of similar episodes 6 months back and got admitted in some other hospital. Upon discharge, he was started on metered dose inhalers, advice regarding smoking cessation and pulmonary rehabilitation, to which patient was non-compliant. On examination, he was hemodynamically stable with GCS of E2V2M5, no focal neurological deficit. Random blood sugar was 201 milligram per deciliter, and chest auscultation revealed extensive bronchi bilaterally. ABG showed acute on chronic respiratory acidosis with metabolic compensation. So with this kind of case, it is evident that this patient is suffering with obstructive pulmonary disease, and the patient is having now CO2 narcosis, and ABG shows the same, and you have to manage such a case. So obstructive lung diseases are divided into COPD and asthma. Okay, so there are two types of obstructive lung diseases, and in COPD, sometimes they might ask you what are the types of COPD. So it is of two types: chronic bronchitis and emphysema. So any COPD can become unstable and known as acute exacerbation of COPD or AECOPD. So this is the acute form of COPD. COPD is otherwise a chronic disease. Similarly, asthma is also a chronic issue, but sometimes they also get exacerbation acuteness, and this acuteness is termed as status asthmaticus. In this video, I am going to focus mainly on the five important points: the definitions, the trigger and etiology of COPD. Then we will discuss about pathophysiology, because that's so important for examinations. So for the examination going students and postgraduate students, etc., it's very important. And then we will also learn about how to assess severity of COPD or acute exacerbation of COPD both. And then we will discuss the management part, especially the AECOPD management. So according to GOLD, that is GOLD, Global Strategy for Prevention, Diagnosis and Management of COPD. So GOLD has a website, and this is so 2022 report, according to which COPD is defined as a preventable and treatable disease characterized by persistent respiratory symptoms and airflow limitations due to airway or parenchymal abnormalities, usually caused by exposure to noxious particles or gases and influenced by host factor including abnormal lung development. So it is kind of a spectrum of disease, you can say, which is characterized by persistent respiratory system symptoms and airflow limitations. So these are the triggers which can lead to exacerbation in a COPD airway, which is already constricted. So due to some trigger factor, it can go into this kind of a state where it is almost getting blocked. This is acute exacerbation of COPD, which is defined as an event. It is an event in the natural course of COPD characterized by change in the patient's baseline dyspnea, cough, and production of sputum. These three things. And that is acute in onset, beyond normal day-to-day variation, and may warrant a change in regular medication. In other words, it is an acute worsening of respiratory symptoms that result in additional therapy. The main cardinal symptoms of acute exacerbation are cough, which increases in frequency and severity, the sputum production, which increases in quantity, and also it changes its characteristics, and also the dyspnea, which worsens in acute exacerbation. So let's talk about the pathophysiology. So pathophysiology, a hallmark of COPD is mainly irreversible expiratory airflow limitation caused by an increase in the resistance of the small airways or an increase in the lung compliance due to emphysematous lung destruction, or both. So there are two problems: either there is increase in the resistance or increase in the compliance due to emphysema. So increase in the resistance can occur in chronic bronchitis, and increase in the lung compliance can occur in the emphysema. And we know both are included in the pathophysiology of COPD, or there are types of COPD. Sometimes there may be a predominant component of each, but sometimes they may be having mixed pathophysiology. The product of resistance and compliance is known as time constant, so that we have to learn the fundamental of time constant. So time constant is equal to R into C. R is resistance and C is compliance, and this time constant reflects the time which is required for lung to empty, and this time is increased in the COPD patient. So naturally in COPD patient it takes time to expire fully, and these patients are not able to do so due to airway resistance which is increased. What is the cause of expiratory obstruction? So the cause is basically the excessive mucus secretion, mucosal edema, and increase in the fluid and cell exudation in the airway. So these three things which are the part of inflammatory process triggered by smoking or inhaled noxious particles, or sometimes infection. So these triggers can cause the acute exacerbation. Let's understand about hyperinflation. What is that? So dynamic hyperinflation or hyperinflation is a characteristic feature common to patients with acute exacerbation of COPD, or even sometimes asthma, status asthmaticus. Two central pathophysiological mechanisms can lead to hyperinflation. One is airway collapse leading to total expiratory airflow limitation and volume trapping, and other mechanism is increased airway resistance leading to increased expiratory time, that is time constant, and dynamic hyperinflation. The first mechanism is predominantly seen in COPD patients. So here in this figure you can see that each time at the end of expiration there is some volume which is trapped. Again, in the next inspiration, increased volume is trapped. Another expiration, at the end of expiration, there is again some more volume is trapped. So the trapped volume increases slowly, and that is the hallmark of hyperinflation. So lungs become inflated, inflated, and inflated, and there will be development of auto PEEP, that is intrinsic PEEP. So that also leads to increased resistive work of breathing. So how does airflow obstruction affect the respiratory mechanics? That is very important question people might ask you. So it increases the resistance, increases the pressure gradient necessary to overcome the airway resistance for a given airflow, the development of auto PEEP due to hyperinflation. So development of auto PEEP dramatically increases the inspiratory trigger over workload. So more effort is required to generate the inspiration. So that is inspiratory trigger workload will increase due to intrinsic PEEP. At the beginning of each inspiration, auto PEEP must be first to overcome before air can flow in during a spontaneous breathing, or to trigger the ventilator during assisted mechanical ventilation, that is triggered work. So work of breathing definitely increases, and that work of breathing is known as resistive work of breathing. So this is very good PV loop. This is expiratory work of breathing. In A, it is normal. In A part of this curve, the PV loop, it is normal. And what happens due to intrinsic beep, this whole curve shifts on the x-axis, right, and due to which the work of breathing increases. Okay, so that elastic work also increases due to intrinsic beep. And there is also development of dynamic hyperinflation. So that means that there is volume trapped in at the end of expiration always. Okay, so this shift, this loop, PV loop, shifts towards the right and shifts little bit up. So it shifts to the right due to intrinsic PEEP development, and it shifts up due to development of dynamic hyperinflation, or otherwise known as volume trap. And that increases the work of breathing, especially the elastic work of breathing. So PEEP increases the elastic work of breathing. Now, in moderate to severe COPD, lung hyperinflation places respiratory muscle, especially the diaphragm, at a significant mechanical disadvantage. That means that diaphragm has to work more. So what happens in COPD or emphysema, you can say that diaphragm, due to hyperinflation, diaphragm becomes flattened. And because the diaphragm becomes flattened, they can't go down further during expiration, and that leads to decrease in the efficiency of breathing. Okay, dynamic hyperinflation, as we know, is a feature of respiratory system to return to the elastic equilibrium volume. And what happens during end expiration, there is some volume which is trapped, and that leads to development of intrinsic PEEP. And this diaphragmatic hyperinflation uh, is common to both asthma and COPD. So it increases the elastic work of breathing due to, as I've shown in the PV loop diagram, there is an increased elastic work of breathing. There is increase in the intrathoracic pressure due to development of IPEEP, and also it can lead to diaphragmatic dysfunction. Okay, and all these can lead to patient ventilator dysynchrony, ineffective triggering, etc., and ultimately leads to hypoxemia and hypercapnia. There will be reduced mechanical, what you call alveolar ventilation, and increased carbon dioxide over time. So how will you evaluate and triage such patients? So both acute exacerbation of COPD and acute exacerbation of asthma leads to type 2 respiratory failure, and ultimately the end result is respiratory arrest and death. So we have to prevent. Therefore, mechanical ventilation is very crucial to prevent this process of disease ultimately leading to respiratory arrest and death. And this is first important intervention, that is mechanical ventilation is the first important intervention to be done. So the assessment of COPD exacerbation is done by either medical history or clinical sign. Medical history should focus on the questions which can assess the severity of COPD based on the degree of airflow limitation, duration of worsening, or new symptoms, or should also be asked. And how many times patient has been hospitalized in the past, and also what are other comorbidities apart from COPD patient has, and what is the present treatment regimen, whether it contains one bronchodilator or two bronchodilator of same class or various classes, steroids, etc. And also it should focus on the previous history of hospitalization, as well as the ICU admission, as well as the mechanical ventilation. On examination, how will you assess COPD exacerbation? Look at the accessory muscles. Accessory muscles working means COPD is quite severe. Whether there is a paradoxical chest wall movement means that during expiration the chest wall goes in. If there is a worsening or new onset central cyanosis, that is quite severe COPD. Development of peripheral edema means that there is a component of cor pulmonale or right ventricular failure due to COPD. You can also look at the blood pressure if there is a drop in the blood pressure of the or the patient has right ventricular failure that is that is leading to a shock state. It means that the COPD is quite severe. And ultimately, if the mental status is altered of the patient is drowsy, that means that patient is developing CO2 narcosis due to ineffective alveolar ventilation. All these clinical signs can help you to uh, triage the patient and also to guide your treatment options, especially initiation of mechanical ventilation. And if the patient is having respiratory acidosis, definitely that is important indication of initiation of mechanical ventilation in the form of NIV first and invasive mechanical ventilation later. So what is the subjective way of classifying? So ultimately you can take the help of this table where type 1, type 2 and type 3, that is severe, moderate and mild exacerbations are characterized. 1 means severe exacerbation, that means the patient has dyspnea, worsening dyspnea, sputum volume is more and lot of yellowness, prurulence. How will you classify a COPD? So there is a ABCD, latest is ABCD COPD classification, which combines the data from the severity. So that is on the left side, y-axis of this um, square graph, and then data from modified British Medical Research Council questionnaire MMRC or CAT, that is COPD assessment test, and that is on the x-axis, and again on the y-axis on the right side there is a history of patients exacerbation to classify patients into now 4 groups. So these 3 major uh, criteria, and then we can classify the patient into 4 groups. So A means is green, that means fever symptoms. B means more symptoms. C more fever symptom with the high risk, and D, which is the red actually, which is the worst, with the most symptoms with the high risk. So now let's understand what is on the left side. So left side there is a risk of gold uh, gold classification of airflow limitation. So this is 1, 2, 3, 4. 4 gold severity scale: mild, moderate, severe, very severe. This is given by the gold guidelines, which classify patients into 4 different categories. Gold 1 is mild, gold 2 is moderate, gold 3 is severe, and gold 4 is very severe, which is based on the level of airflow limitation, and this is assessed by performing a spirometry. Patients should be able to do a spirometry. So obviously critical patients are quite sick to do that, but at least you can ask for a spirometry result which was done previously to document this gold uh, assessment, gold severity class. Okay, and that depends on post bronchodilator FEV1. So FEV1 is the amount of air which you can force from your lungs in 1 second. That is FEV1. More than 80% is mild, 50 to 80 moderate, 30 to 50 severe, and less than 30 very severe. Now, what is MMRC? MMRC is the Modified Medical Research Council questionnaire, which is widely used to assess the severity of breathlessness in patients with COPD, starting from grade 0 to grade 4. Grade 0 is if you get breathless with strenuous exercise, okay, which is quite common with even healthy lungs. And grade 4, even breathless on the rest, or breathless to leave the house, or breathless while dressing. So that is grade 4. So if MMRC grading is more than 2, that means the patient has more symptom. Now category, that is CAT. What is CAT? CAT is COPD assessment test. So how do you perform? So you have a questionnaire like I I never cough, I have no phlegm or mucus, my chest does not feel tight at all. When I walk uphill or one flight of stairs, I am not breathless. I am not limited doing any activities. I sleep soundly. I have lots of energy. Okay, so this is normal 0, and opposite is grade 5. Okay, so patient has, this is the kind of ordinal scale patient has to tick. um, so like here, if you tick, um, I have no energy at all, so that is 5, and I have lots of energy. Suppose patient takes 4, and here patient takes 3. I am not all confident leaving my home because of my lung condition. So 4, 3, 7, and suppose patient, my chest does not feel tight at all. So that is 2, and I have a lot of cough, 4. So it means that CAT is more than 10. If CAT is more than 10, patient has more symptom. So CAT combines the data. So CAT is very important assessment of patient's exacerbation, history of exacerbation. So how will you treat the patient? That is also very important. So management. So management depends on COPD care bundle, which can be memorized as the mnemonic DART, D-A-R-T. So D-A-R-T, D means diagnosis. Okay, diagnosis of acute exacerbation of COPD as soon as possible in patients who are already diagnosed with COPD or spirometric evidence of even less than, upon FPC less than 0.7 with worsening of symptoms, physical examination, radiological features suggestive of acute worsening. A means assessment for the need of oxygen supplementation to maintain the saturation between 88 to 92%. R, you have to recognize and respond to treat the respiratory acidosis at admission. So for that you need to do an ABG. If ABG shows, ABG has to be done. If ABG shows pH less than 7.35, that is acidosis, or PCO2 more than 50, that means the patient has developed a respiratory acidosis. So you have to recognize that and respond to treat this. Okay. T is timely management with steroid, that is IV steroid or systemic steroid, or nebulization of steroid, and also bronchodilator. Steroid and bronchodilators have to be started as soon as possible. Once you recognize, you diagnose, you assess, okay, and start oxygen. After oxygen, you have to give a steroid and bronchodilator. So what are the treatment options available for ACOPD patients? So there are two types of options: pharmacological options and non-pharmacological or supportive options. So in pharmacological options, you have to start oxygen, give bronchodilator, nebulization, start IV steroid, antibiotics, antiviral. Then there is some role of magnesium sulfate, not much, but Heliox has a still role, but especially in asthma. So these two have not much of role, but antiviral, yes, you can consider if you are suspicious of H1N1 or recently corona. So both pharmacological and non-pharmacological treatment are instituted depending upon the severity of the disease. A patient has very severe COPD, then you have to start the patient on mechanical ventilation or HFNC or extracorporeal CO2 removal devices. So what is the role of oxygen therapy? How much you have to give? So you know that supplemental oxygen increases the oxygenation, and that's important because patient may have pneumonia and patient requires some oxygen to maintain the saturation, to meant to prevent the organ damage, okay, and organ damage, and to improve the oxygen delivery to the tissue. But what happens if you are giving excess of oxygen? That oxygen can displace the carbon dioxide from carboxyhemoglobin and can lead to carbon dioxide retention. Okay, so that's the possibility. So CO2 will be released, and that can lead to CO2 narcosis. Another theory is that CO2 can cause the neural depression, okay, the drive. So what happens? Respiratory drive also decreases, but this is a theoretical fact only. Nothing is proved. The neural drive is decreased, normalization of pH. Okay, so CO2 is basically is a drive to breathe in COPD patient. And what happens when you give oxygen? So this CO2 is washed out, and when CO2 is washed out, then what happens? The patient goes to apnea. Okay, they have carbon dioxide on the higher range. Okay, so up to, you can say, 60 to 70 PaCO2 is actually normal in case of chronic obstructive pulmonary disease patients. They no longer respond to stimulus of up to CO2 of 70. They require probably higher. And they are only triggered for respiratory drive is the level of oxygen, because they no longer, or they do not respond to carbon dioxide stimulus. They respond to hypoxic stimulus. So when you give higher oxygen level, that oxygen can lead to uh, that hyperoxia leads to loss of respiratory drive, and that can lead to apnea. That is a theory. And then there is another theory that if you give oxygen more, it can leads to loss of, or what you call the protective pathophysiology, that is the hypoxic pulmonary vasoconstriction. So what happens? The HPV, suppose this is a deceased alveoli. This is the deceased alveoli. And here what happens? The HPV vasoconstrict the artery around this alveoli. This vasoconstriction is actually a an advantage, or it is a beneficial response. So this beneficial HPV response, or hypoxic pulmonary vasoconstriction response, is gone when you are giving high oxygen concentration, and this vasodilation will ultimately imbalance, will cause a kind of situation, the mismatch between ventilation and perfusion in good alveoli. Okay, and that results in shunting, dead space ventilation, and eventually hypercarbia. That is why they say that we have to keep the oxygen to lower level, and the target of saturation which has to be maintained in COPD patient is 88 to 92%, and for that special graded oxygen delivery device is suggested to be used, and that is called Venturi mask. So you have to use the Venturi mask, and you have to give FiO2 not more than required to keep the saturation more than 92%. So you have to give less FiO2. Okay, so FiO2 of 0.25 to 0.3 is enough. Okay, in normal COPD patients. Then what are the types of bronchodilators used in the treatment, and what is their role in combating pathophysiology of ACOPD? So you know, acute exacerbations are due to um, bronchospasms, and these bronchospasms are reversed by the bronchodilators, especially beta 2 agonist. So there are only two types of bronchodilators based on two specific receptors on the airway epithelium: beta 2 agonist and anticholinergics. Beta 2 agonists are the specifically short acting beta 2 agonists like salbutamol and levosalbutamol relaxes respiratory smooth muscles and increase the airflow in expression. It also augments mucociliary clearance. It enhances the vascular integrity. It enhances the metabolic responses, and also inhibits the mediation of mast cell basophil activation. So various roles of beta 2 agonist. The doses are very important to remember. So we give salbutamol in the dose of 2.5 milligram, 2.5 milligram salbutamol, okay, in 2.5 ml of saline. We mix together and give as a nebulization every, we give as a nebulization every 2 to 4 hourly. And if we are talking about a levosalbutamol, we need lower doses, 0.125 milligram every 4 hours, okay, and or even every 8 hours. Also levosalbutamol is given less frequently, and reported efficacy of MDI is as good as nebulizers, so there is no difference. If you want to give as a MDI, a patient can take MDI, should also can be advised in place of nebulization. Okay, so we were talking about the anticholinergic. This is the second type of bronchodilators which are used in COPD, acute exacerbation of COPD patients. So especially because acute exacerbation is short-lived, it is acute onset, we require treatment faster, so we give short-acting antimuscarinics. Okay, so ipratropium and tiotropium are the short-acting antimuscarinic, otherwise known as SAMA, short-acting muscarinic agent, SAMA, and these are called SABA, short-acting beta-2 agonist. But epratropium, along with beta-2 agonist for the effective bronchodilation, and these can smooth muscle relaxation and decrease the mucus secretion. Somebody asks you what is the added advantage of anticholinergic compared to beta-2 agonists. So anticholinergic can also lead to drying of secretion. The dose of tiotropium is 0.5 milligram in 2.5 ml NS, and we give nebulization every 6 hourly to 8 hourly. This is the dose. Now, what is the role of methylxanthine? So some people use deriphyllin, doxyphylline, aminophylline, etc. So remember that they are not very well recommended according to Gold Guidelines 2022. Methylxanthines are potent phosphodiesterase inhibitors and adenosine receptor antagonist, which have been recognized to have a direct bronchodilatory effect. It also reduces the airway responsiveness to histamine, adenosine, methacholine, and allergens, etc. But they are not recommended by current guidelines, as a first-line bronchodilator, but can be used with caution as a part of second-line drug in patients who do not respond to the first-line beta-2 agonist or anti-muscarinics. Okay, so these two drugs, suppose we are not able to achieve the bronchodilation for patients with COPD, then we can use methylxanthine. But always remember, they have significant side effects like seizures and cardiac arrhythmias, which are considered very common side effects, 10 to 15 times, especially in elderly with toxic blood levels of methylxanthine more than 20 microgram per ml. So whenever you are using methylxanthine, remember they have very narrow therapeutic uh, level in the blood, and anytime you may find that patient is developing cardiac arrhythmia or even patient is developing seizure. So you have to be very careful while you are using such agents. So they can be used, as I said, in selected cases when there is insufficient response to the first line bronchodilator, that is SABA and SAMA. Now let's discuss about the steroid. What is the role of steroid? Steroids can speed up the recovery by improving the FEV1 and FVC. They can reduce the hospital stay, they can reduce the ICU stay, they can reduce the mechanical ventilation, they can decrease the chance of recurrent hospitalization. Okay, these are the long-term effects of steroid, but acutely they can help with reducing the inflammatory edema and improving the expiratory airflow. So what do we use? We use prednisolone, which is recommended in the guidelines, but for acute exacerbation we can use hydrocortisone. Hydrocortisone can be used as 200 milligram per day dose, and if you are using prednisolone we can use 40 milligram per day. Okay, and what is the duration of steroid to be given? So duration should be kept shorter, from 5 to 14 days. So that is recommended as per Gold Guidelines. You can give methylprednisolone as well. So we require, because we require more data. It's not like it's contraindicated. You can use methylprednisolone. The dose should be equivalent to 40 milligram of oral prednisolone. We can use inhaled steroid as well. So high dose, but inhalation we have to give high dose. So high dose budesonide, 4 to 8 milligram per day. That is the dose. Has similar effect to the oral glucocorticoid in respect to change the FEV1 and PaCO2. Most of the exacerbations in COPD are due to infections, and the pathophysiology behind exacerbation is usually, as we know, infections due to Haemophilus influenzae, which is the most common bacteria implicated, followed by Streptococcus pneumoniae and Moraxella catarrhalis. So these three bacteria, which you should remember: Haemophilus influenzae, Moraxella catarrhalis, and Streptococcus pneumoniae. These are the most common bacteria implicated in exacerbations, followed by viruses. Okay, so Pseudomonas aeruginosa is also common, especially in emphysema and bronchiectasis patients. The recommended length of the duration of antibiotic therapy is usually 5 to 7 days. When you want to give antibiotic, give it for at least 5 to 7 days, and always perform a chest X-ray to look for pneumonic patches. You can perform even HRCT to grade the severity of pneumonia. So what are the adjunct therapies? So you can, depending upon the clinical condition of the patient, you can have appropriate fluid balance, especially the zero balance or even negative balance. You can use diuretics, you can use the dialysis to attain the negative balance and dry patients, and anticoagulants can be used. Treatment of comorbidities is very important while you are treating a COPD exacerbation. You have to build up the nutrition. You can give IV parenteral nutrition and oral nutrition supplemented. Okay, at all times, healthcare providers should vigorously enforce stringent measures against active cigarette smoking after discharge. Sometimes patient may develop, pedal edema due to for pulmonary. And when you do echocardiography in such patients, you may find these features of uh, right ventricular hypertrophy, right ventricular dilatation, and also pulmonary hypertension. So you have to manage cardiac component of COPD as well, so that the severity of disease can be controlled, and later you can have a good outcome. Okay. Such patients, the COPD exacerbation patient, are at risk of DVT and pulmonary embolism. Therefore, anticoagulants should be given in such patients. So, what is the role of N-acetylcysteine? Usually, we prescribe N-acetylcysteine, Mucinex, Mucomex, etc. These are the brand names. So, what they are all mucolytic agents. So, it is said that mucolytics are important in the management of acute exacerbation. Truly, they are not recommended in the treatment of acute exacerbation. But if you feel that patient has obstructive symptoms, despite the management, proper management of the disease, then probably you may think of N-acetylcysteine administration, oral or nebulization. So thank you so much for watching part 1 of this obstructive lung diseases.